Here. Welcome, everybody. I am Julie Moody-Freeman, and I'm the director of the Center for Black Diaspora at DePaul University. Before I get started, I want you to, even before I introduce Dr. Blackstock, I would like to introduce you to my co-host, Juelle Daley, who is the assistant director at the center. Juelle is here. She will definitely help me just in case, we have any technology issues and I drop off. We'll always have somebody here with you. So welcome. Before I get started, I want to acknowledge a few people who in some way have made this event possible. So I'd like to start with Farad DeBerry, who is right there. Farad DeBerry is at the center, Jessica Williams and Jennifer Ugumiki, who are the student workers, and Jennifer made the flyer for this event. So we'd like to thank her for that beautiful flyer. I'd also like to thank one of my colleagues, Dr. Lori Pierce, in the Department of African and Black Diaspora Studies, and Moody, who is in Belize, who helped with research. Thanks to Deborah Holt Noel from UNC TV. And also a special thank you to the Dean's Office, Dean Guillermo Vasquez de Velasco, Molly Bench, Susana Pagliaro, and Associate Dean Dr. Jacqueline Lazou. And then finally to all the centers and institutes in the College of Liberal Arts and Sciences, thank you for helping to promote this event. And now for Dr. Blackstock. Dr. Blackstock received both her undergraduate and medical degrees from Harvard University. She was formerly associate professor in the Department of Emergency Medicine and the faculty director for recruitment, retention, and inclusion in the Office of Diversity Affairs at New York University School of Medicine. She left NYU School of Medicine in December 2019 after almost 10 years on the faculty to focus on advanced health equity. She is the founder and CEO of Advanced Health Equity, which partners with healthcare and healthcare-related organizations to address the critical factors contributing to health inequity through talks, workshops, and consulting services. In 2019, Dr. Blackstock was recognized by Forbes magazine as one of 10 diversity and inclusion trailblazers you need to get familiar with. Her writing has been featured in Chicago Tribune and Stats News for the Boston Globe, etc. So please welcome Dr. Blackstock. Thank you so much for taking the time to be here with us.
Well, thank you so much for having me.
Can you talk about your medical training and why you decided to specialize in emergency medicine?
Sure, of course. But I'm going to go a little bit further back. I don't know if you know, but my mother was a physician. My mother, grew up in Brooklyn, New York, the same neighborhood I was raised in. She was raised by a single mother, 6 siblings, and she was the first person in her family to go to college. She attended Brooklyn College and had a chemistry professor there who had encouraged her to apply to medical school. It was something that she had thought about, but her teachers had discouraged. But this one chemistry professor said, I think you can do it. So she applied to all of her medical schools, and she got into every single one, and she ended up matriculating at Harvard Medical School. Mm-hmm. And so she ended up coming back after medical school to New York City, trained at Harlem Hospital in internal medicine, did a fellowship at Brookdale Hospital in Brooklyn, New York, and then served her own community, the same community she grew up in for many years. My sister, I have a twin sister who's also a physician, and we actually ended up losing our mom when we were in college. We were 19 years old. She passed away from acute myelogenous leukemia, but she obviously was our role model in so many ways, not just to become a physician, but also seeing her commitment to our community, to serving our community, and raising us with those same values. And so when I ended up going to medical school, my sister and I and my mom, we were the first Black mother-daughter legacy from Harvard Medical School. And that means a lot to me, not from my accomplishments, but really speaks to my mother's accomplishments of having to really jump through structural barriers, right? To get to medical school despite her, the environment that she was raised in. And so in medical school, I thought about different specialties, and I really decided on emergency medicine because to me that was a specialty where you get to take care of everybody. It doesn't matter, what their socioeconomic background is, but more specifically, I know that because of our healthcare system and because it is so dysfunctional, that many of the people that I would be serving in the emergency department would be people that look like me, that are, unfortunately do not have, primary care, so, available to them. So they're using the emergency department for their primary care. And so that was one of the major reasons why I did go into emergency medicine.
Can you talk about how that training in emergency medicine has helped you treating patients who have contracted the coronavirus?
Yes, absolutely. So emergency medicine, I think when people hear it, they wonder, what it is. They know about the show ER. And
Yes.
so really what it is that we see patients that come in, we call undifferentiated. People come in with chest pain, or they come in with cough or shortness of breath. And really it's our job as emergency medicine clinicians to rule out the most serious or life-threatening diagnoses or causes for their symptoms. And so if someone comes in with chest pain, for example, we want to make sure they're not having a heart attack or pneumonia or a blood clot in their lungs. And so what we've been seeing, with this pandemic is we've been seeing a lot of patients coming in with breathing difficulties and weakness from COVID-19. A lot of them have a history of fever and cough for several days. They're coming in short of breath with low oxygen. They need supplemental oxygen, so they need oxygen masks, or they may be so sick that they need to be placed on a ventilator.
So I want to back up a little. And I am interested overall in this event about the impact of the virus on Black communities in the United States. But before we talk about that, could you talk a little about the anatomy of this virus itself, right? How did it start? What does it look like? What should we expect to see?
Given what we had heard about coronavirus and COVID-19 out of China and Italy, knowing that it affected people with underlying medical problems like diabetes, high blood pressure, and asthma, which are medical problems that are prevalent in our community, I knew that our community would be very, very heavily impacted by that. But what was interesting was actually seeing that in person. So I currently work in urgent care clinics in central Brooklyn. Typically, our patient population is racially, socioeconomically diverse. But I'll say starting in early March, we started seeing a shift. We started seeing more Black and brown patients. Many of them were essential workers and service workers who were coming in with typical hallmark COVID-19 symptoms. And so I noticed this, and then I asked our staff who also look like me, and I said, do you notice that our patient population is shifting? And they said, yeah, it's mostly Black and brown patients. And so, while many of us who do health equity work could have and had predicted this, and we're seeing that in some of the preliminary data coming out of major cities throughout the country, but it was obvious that our Black communities were being most heavily impacted. Most people will complain of cough, and most people will complain of shortness of breath. A majority of them will have fever as well. They've also been complaining a lot about chest tightness.
Yes.
But chest tightness, shortness of breath, and cough are really the major symptoms they're coming in with. And some people come in with other symptoms. It's very interesting. Some people may come in with belly pain or have fallen because they're weak. And I end up doing a workup on them, doing a chest x-ray, and I see they have COVID-19 pneumonia. And then when you ask them, they'll say, well, I wasn't feeling so great. Mm-hmm. The typical symptoms are cough, shortness of breath. Some may have fever, some may have chest tightness. Some also have diarrhea. About 20% of patients may complain of loose stools. You typically won't see patients complaining of nasal congestion or runny nose or itchy eyes. Those are more, runny nose is more other kind of cold viruses or maybe even allergies. Same with itchy eyes. Itchy eyes are more consistent with seasonal allergies. And so what's interesting is that we're at that time of year where people are having allergies, seasonal allergy symptoms. And we have people coming in and some of them are concerned they have COVID-19, but we go through their symptoms, we check their vital signs, we see what their oxygen level is. I listen to their lungs. We may or may not get a chest x-ray depending on what their oxygen level is. So they need a workup.
Yeah. So if you compare maybe end of March to now, are there any indications cases are fewer, or do you think it's increasing?
No, that's a great question. And so what I've been very excited about seeing over the last few weeks is that here in New York City, the physical distancing is working. Okay, we're seeing a drop in our patient volumes, the number of patients that we're seeing with COVID-19 symptoms substantially. Also, I'm seeing patients who have recovered from COVID-19, many of them also essential workers who are preparing to go back to work. And so some of my concerns about that are, making sure that they have personal protective equipment to wear to work, because there's so many things about the virus that we don't know. We don't know how long someone is infectious for, right? So we don't know if someone's going back to work after 3 weeks, do they pose a potential, health threat to their coworker? And then also you want to make sure that they are in the best health possible. The other thing is what we're seeing is some of the people with COVID-19 may have long-term symptoms. So they may have prolonged cough, or they may have shortness of breath that lasts for several weeks. For some people, this isn't a virus that lasts for 3 days. It's several weeks long.
And is there a possibility that they can contract it again? Do we know that at all?
So there's so much that we don't know about coronavirus. We don't know, and so right now there is a test people may have heard about, the antibody test. And so there are two tests. There's a PCR test and an antibody test. The PCR test is a test that is the nasal swab. It detects the virus. The antibody test, however, is the test to see whether or not you have antibodies in your blood to coronavirus. And so you would have antibodies if you were exposed to coronavirus, if you actually had had the virus and recovered from it. But what we don't know about those antibodies is whether someone is fully immune or partially immune to it, whether they can get it again, and then also how long they have immunity for. Is it a year, 2 years, or 3 years? Because we know, for example, like the flu, that we have to get a flu shot every year, right? Because the flu shot that you had last year may not work for this year because there's a different strain of the flu virus.
Right. Let's talk about it in terms of Black population. Now, earlier this year, there was the myth going around, right? On Twitter, for example, that the virus did not affect Black people. So we now know, we know that this is not true. So why are Black communities being disproportionately affected?
Right, that's such a great question. And I do want to talk a lot about the myths because I feel the myths were very prevalent on social media in the beginning. And I also feel like I'm still hearing some of the myths. I don't know if you've heard about this idea about people think that the coronavirus is linked to the 5G cell service. And so, those myths can be very harmful for our communities in particular because we are the communities that are the most vulnerable. So as I mentioned before, we carry the highest chronic disease burdens that make you more susceptible to developing serious complications of COVID-19. And so what I want to make clear is we carry those higher chronic disease burdens, not because there's anything biologically wrong with us, but that is a result of legacy of structural racism in this country that has left our communities marginalized, disinvested in. So we have not only difficulty accessing care, we have difficulty accessing quality care. And then we also have differences in life opportunities compared to other communities, all due to practices and policies of structural racism.
So how does it affect Black populations based on where they live, based on class, gender, age, or any other factor?
Right, so we're seeing that, definitely for those of us who are, essential workers. So many of my patients, they work in transit, they work for the Postal Service. Some of them are corrections officers. So their jobs basically leave them exposed to the public, right? And so I was actually told by one of my patients that when this epidemic first started, they were told, he works for the MTA, so the transit system here in New York City, he was told that he would not to use masks because that would make the riders scared. So if you can imagine, how even more exposed workers were not being able to wear personal protective equipment. So we basically have jobs that put us on the front lines. We're more likely to live in housing that's defined as crowded, where there's more than one person per room in the housing unit. We're also more likely to rent, so we don't have houses that are large where we can really physically distance ourselves from each other.
I want to talk a little about how Black populations are treated if you have the virus. Do you think that racism, structural inequality play any role in how Blacks with the symptoms are treated? Let's say, for example, when they go to the emergency room or, or to a doctor, or even for an ambulance ride.
Right. No, so definitely one thing I want to make clear, and I think for the masses out there who are they're hearing about racial health disparities for the first time. I think we know in the Black community, or those of us who do health equity work, that these inequities have been around for a very long time. And so when we think about Black communities interfacing or interacting with the healthcare system, there is a very long history of Black people not being taken seriously, our complaints not being taken seriously. And this is very well documented in the literature. So we know that even when it comes to how pain is treated and how pain is perceived, that there are disparities in how much pain medication Black patients are given. So even thinking about the opioid pain epidemic, there was a reason why white patients were the first group of patients to be afflicted. And that was because you had clinicians who were more likely to give narcotic pain prescriptions to white patients versus Black patients. We also have, a lot of data and literature that shows even for patients coming in with appendicitis, patients coming in with open thigh bone fractures. And so that's a very painful fracture of your thigh bone. No one's going to say that doesn't hurt, but we have literature that shows that Black patients are given less medication than white patients, even with that. And also we know that the Black maternal mortality crisis has received significant amount of press over the last few years, but it really is a critical issue. We have Black women dying in and around pregnancy at rates higher than in Mexico, where half the population lives in poverty. And so we have this legacy of Black people not being listened to. And so you could imagine that now within this epidemic that we're seeing basically the same sort of interactions. And we've already seen that in the media across the country in various cities, Black patients having to return to the emergency department several times, some even 3-4 times, not being tested, or not being taken seriously, sent home, and then coming back critically ill or even dead.
Yeah. I wanted to ask a question about tracking of how Black, queer, and transgender populations with coronavirus are treated. Do we have any information on that?
Thank you for asking about that. And I did some research on this before we spoke today. And my twin sister is actually the assistant commissioner for the Bureau of HIV for the Department for New York City. And we talked about this the other day. And unfortunately, that data is not easily accessible. And of course, that's by design. That's not a mistake. To get the sexual orientation, gender identity data, you actually have to match patients' electronic medical records with their discharge diagnosis or their death diagnoses. And so it's not an easy thing to do. It's something that really should be done in a very organized and controlled fashion, but it isn't. It kind of is along the same reasons why we're having so much difficulty of collecting race and ethnic demographic data, that has not been prioritized like age and gender. And some of the reasons why is because, you know, it's the system working as designed, making it difficult for us to find out that it's our communities that are being the most heavily impacted and disproportionately so.
Yes, thank you. So let's talk a little about Black health providers and COVID-19. Can you walk us through your workday? How do you protect yourself and your family from the virus?
Sure, and that's such a big concern, because I will say for the first time ever, I have fear about going to work, because I'm worried about going to work, catching coronavirus, getting sick, and not just that, but also bringing it home to my family. I have two small children. I have a 3- and 5-year-old. And so these are very, very real concerns. But when I get to work, our manager has all of our personal protective equipment geared up. We have gowns, we have shoe covers, we have masks, we have eye shields, and we have hair covers as well. And even when when I see a patient, I make sure to wash my hands, change my gloves before that patient. When I come out of the room, I take those gloves off, wash my hands again. I probably wash my hands probably over 200-300 times in a given shift. But I also don't want to get one patient sick because I've interacted with another patient. So, you know, it has increased the level of concerns and anxiety at work. I think also wearing the personal protective equipment, it literally creates both a physical and literal barrier between you and your patient, because they also can't really see your face. So your face is covered. They can't see what facial expression you're making. It really has changed, I think, the relationship between patient and clinician. Really, there is a lack of support for healthcare workers just in general, right? And so I was talking to a friend recently and saying, who also trained with me, and saying that we typically see a lot of death at work. You know, I have had shifts where I have to take care of a patient who has tried to revive a patient who comes in with cardiac arrest after hanging themselves. We lose them, and then I have to talk to their family. And then after that, I go home or I go on to the next patient, right? And so, you know, there really is not a lot of processing. And so it's really, we have to look out for ourselves. There are resources out there, but definitely we also have to look out for ourselves. I have a therapist. I'm very lucky to have her. I have a Black woman therapist who, I don't know what I would do without her, but definitely in this sort of the crisis that we're in, staying connected with loved ones, going to therapy, meditating, doing what you can to stay grounded and centered in very scary times.
Yeah. So what would be the one advice you or any other healthcare provider on the front line of this epidemic would give to individuals in the Black community or to Black leaders?
Yeah, no, so I think that, what I've seen, what we've seen so far in terms of the numbers of the cases and the deaths, in our communities to COVID-19, obviously, we need to shift and have an explicit, intentional effort directed at our communities. So widespread testing is something that, has been difficult to find because it's taken so long for companies to ramp up testing, but really it's not too late. We're going to be in this for the next year to year and a half. So we need to make sure Black communities have widespread testing. We need to make sure that there's contact tracing, which is when you identify someone who has the virus, you follow up with everyone that they've had contact with. You test them. If they're positive, then they self-isolate. If not, then they can, they know what their status is. We also have to make sure that we're supporting our communities, whether it's in terms of housing, safe housing, whether it's in terms of financial support, whether it's making sure that our essential workers have personal protective equipment. And then also, I think the messaging between public health departments and our communities has to be more nuanced than just wash your hands and physically distance. We have to work with faith-based organizations, neighborhood coalitions, community health workers, people who are already on the ground in our communities and know the community well, to ensure that the messaging is getting out there, but also the outreach. Like, we need to be going door to door, making sure that our most vulnerable community members, especially the elderly or those with underlying medical problems, are contacted, and even preemptively, there's this idea that, doctors can review their electronic health records. And if a patient hasn't been to the doctor in, say, 6 months, or this is someone with a lot of underlying medical problems, that you proactively reach out to them, see how they're doing, make sure they're doing okay, but also just continue to check in with them in case their needs increase. And then the other thing is this fear that Black communities have about interacting with the healthcare system, which we've talked about why. So it's a valid fear, and we've seen it play out in terms of patients who have gone to the emergency department 3-4 times, and they're not listened to, and they end up dying. And so we really need to have messaging around that as well, not just in the communities, but with healthcare workers and with healthcare institutions as well.
Yeah, thank you for that, because I was going to ask that question. How do we help people maybe get over the fear of going, they want to stay home where they feel.
I know.
Yeah, and then maybe like you wait until the last possible moment, and then maybe it's too late, right?
Well, and that's what we're seeing definitely in New York City, before this pandemic, 20 people a day died at home. Now over 200 people a day are dying at home. And I think when we look at those numbers after this is over, I think we'll probably see that when you look at the racial and ethnic demographic data of people staying at home, I have a feeling that we'll see us as Black people overrepresented in those numbers, because I even have had situations with my patients where I'm in urgent care, they may require a higher level of care if their oxygen is low. And I tell them, if your symptoms persist, I may want you to go to the emergency department. And they refuse. They say, I don't want to go there and die. They're not going to listen to me. And so that is a very difficult conversation to have, because as a Black woman, I understand their concerns. Their concerns are valid.
Yeah. So then at what point, like when should we go to the emergency room? Like, are we supposed to go as soon as we get shortness of breath, or are there alternative treatments, or, because maybe people are thinking, okay, maybe I can hold off.
Right. No, I mean, definitely, I tell patients, if you're having shortness of breath where you're having trouble even saying a few words or taking a few steps, you definitely need to go to the emergency department. Mm-hmm. If you're having chest tightness and mild shortness of breath, you can try to call your doctor if you do have a physician. That's the other thing. A lot of physicians are now doing telehealth visits. And so this is actually where the federal government can help in terms of reimbursement for telehealth visits, to make sure that communities that need it have support for clinicians in those areas, not just physicians, but nurses, community health workers, who actually do want to take care of their patients, but may not have the technology or the platforms to do so.
Yeah, I just want to ask you a little about advancing health equity. Could you talk a little about it? Why did you create the organization? What is your role? And how do you think your organization can assist during this time?
Right, thank you for asking. So I created Advancing Health Equity because I had, in my 10 years of working in academic medicine, seeing patients in the emergency department, it became clear to me that healthcare organizations, whether they be departments of health, whether they're academic institutions or large healthcare systems, really don't have the training or perspective to ensuring that health equity is achieved, especially in terms of targeting health disparities in Black communities. And that can come from different approaches. So ensuring that we have workforce diversity, ensuring that, a lot of them, want unconscious bias training. And I will say about unconscious bias training that I think that is a term that is palatable to predominantly white institutions. But the fact is that this unconscious bias is really a result of structural racism. It's what happens when you live in and socialize in a racist society. You actually start thinking subconsciously that certain patients don't deserve good care. And it's just as dangerous as, as structural racism and its practices and policy. So I also do racial equity culture trainings. What do organizations need to do in order to create a race equitable culture within their organization so that they can provide the best care to their patients? Because if you have organizations that have problems with power, privilege, and are not addressing racial equity, then what's going to happen in terms of the care that's being delivered to the patients? And so that's why I created my organization, and I've had a lot of interest, and I've decided I would really want to dedicate the rest of my career to focusing on addressing health inequities, because it really is appalling to think that this country, the richest country in the world, one, we have the worst health outcomes, period, across racial groups. But the fact that, Black folks are, Black men have the shortest life expectancy, Black babies have the highest infant mortality, Black mothers, as I mentioned, have the highest maternal mortality, and that this is all preventable, is unacceptable. And so I'm committed to working towards closing those gaps.
Thank you. What do you think the outlook is for the future for Black communities in this era?
So I would like to think that this pandemic is a turning point. I mean, I will say that health-wise, I don't know of anything that's happened recently that's gotten, other than maybe the HIV, that's gotten this much attention, especially, and then in terms of racial disparities. So we're getting a lot of media about this, but what really needs to happen is, Health and Human Services, the Center for Disease Control really need to take a leadership role in this and really think about setting explicit guidelines for addressing racial disparities. But until that time, people like me will continue to sound the alarm around these issues.
Mm-hmm. All right, so I'm going to stop here for now, and I will turn this over to Juelle. While we were talking, I think there were probably quite a number of questions. So Juelle, do you want to lead us with that?
Yes, I just wanted to thank you for your talk. I really enjoyed hearing what you've shared so far, Dr. Blackstock. And there are folks too that are curious to know about issues of ventilators. And the question is from Moody-Freeman, and it have ventilators exacerbated the rate of cure since they have been pretty traumatic to the lungs and the chest?
So exacerbated the rate of cure?
Yes, the question is, have ventilators exasperated?
Oh, worsened it. Mm-hmm.
Yes.
Okay.
The rate of cure since they've been pretty traumatic to lungs and the chest.
Well, yeah, I mean, it seems that, the goal is now not to ventilate patients because we've seen such poor outcomes. I think for the majority of patients, maybe 80–90% of patients that actually end up going on the ventilator, they end up dying. And so I know that right now, intensivists are using other methods, high flow oxygen, putting patients in a prone position, which is like a position on your belly or on your side, really to prevent patients from being intubated.
Okay. Now, someone else has also asked another question that I thought, this is from Cherie. She says, I'm a DNP. Several years ago, we had Ebola. The US did everything to ensure it didn't spread. Ebola came out of Africa. COVID came out of China. And most cases in New York was from Europe. Why was there not the same aggressiveness with COVID-19 as Ebola?
So yeah, that's a great question. I think it probably speaks to our ineffective federal leadership, even though we were given a heads up back in December about this virus, but also the difference between coronavirus and Ebola and some of the other viruses like MERS and the other types of SARS is that this virus has a very high rate of transmissibility, meaning that it is transmitted from person to person more often than other viruses. And then also it has a very high mortality rate as well. So we're dealing with a totally, they call it a novel virus because this is the first time that this virus has been described in humans. And so we're learning a lot about it as it comes. But I do think that, I'm thinking about even in New York City, we could have avoided so many deaths if we had physical distancing put in place, shelter in place, even 3 weeks prior.
Yeah, and this follows up with another question too, where they've asked the question about antibody testing and whether or not, what are your thoughts? Do you encourage antibody testing? What is the role of antibody testing in Black health equity? Do you encourage it?
So, so that's a great question, and I think these tests, we're still learning so much about these tests. So the antibody test is, the test that it detects, how, whether you have antibodies to coronavirus or not. The problem is that there are many different types of antibody tests that are out there. Only a few have actually been FDA approved. Most of them are FDA registered. And so my concern is that because the FDA lagged behind and it took so long to approve the PCR test, the diagnostic test, they're kind of just approving all of these antibody tests without ensuring that these tests are highly sensitive, specific, and have high accuracy. So they do vary test to test. And so that meaning that there are false positives. So, there are times when someone may get a positive test, but they actually didn't have coronavirus, or they may get a false negative test when they actually did have coronavirus. And so I will say that in my experience so far, my organization, we just started doing antibody testing a few days ago, but I have seen positive antibodies in patients who, when they described to me typical COVID-19 symptoms that they had weeks ago, those are the patients. So if you had COVID-19, most likely, you've had it. And even in some of the studies in China and in Italy, the people who are asymptomatic, they're actually not truly asymptomatic, because when you actually go back and follow up with them, they are actually people who develop symptoms a few days later. The incubation period is 2 to 14 days for coronavirus, meaning that you develop symptoms 2 to 14 days after exposure. Most people will develop symptoms on day 5, but if you catch someone between day 1 and day 5, they may not have, they're technically considered asymptomatic.
Right. And so Dr. Valerie Johnson, actually, her question, she's a faculty member in political science, she then asked the question about the use of masks. Masks are said to protect you from spreading COVID to others. How much do masks protect you from those who aren't masked? Are homemade masks sufficient?
Right. No, so this is another great question. So the purpose of the cloth mask that the CDC is recommending that everyone wears when they're outside is, if you are sick, is to prevent other people from getting sick. Okay, but a cloth mask really won't help you from, say, someone who is coughing next to you and has coronavirus. It's not as effective for preventing transmission of the virus from another person to you if you're wearing the cloth mask. But if everyone were to wear a cloth mask, that does help substantially the transfer of the virus.
Right. Okay. There are a couple of other questions here that, and I apologize to everyone who are submitting questions during the chat, the flurry of questions. I will try to get to all of them, and some of them are quite long, so I'm trying to sort of to condense it so that'll be quicker. There's one question here that's, what do you say to members of the Black community who are ignorant of the situation and say, I've been treated fairly, it will not happen to me?
Yeah, that's a good question. I will just say that what we've seen from the data so far, and in Michigan and Wisconsin, in the South, and New York City, is that our communities are being disproportionately impacted in terms of cases, who's hospitalized and who dies. And so, I would say that more often than not, we're the ones that are going to be dying from this. And so, obviously, I would hope that everyone would be able to get equitable care wherever they went, but we just know, based on previous trends in the literature, that probably is not the case.
Okay. And there's somebody who's also asked the question, what is your response to people when they would argue that this shift in COVID cases to more Black and brown people has more to do with underlying health conditions that already, and they put already in caps, exist among Black people, versus more so the social determinants and issues with health equity, access, systemic issues? In your opinion, what do you feel contributes most to this issue? Or is it just simply the combination of both? Is it more systemic, or is it something else, in your opinion?
So I think it's a combination of all of those factors, because the reason why our communities carry that higher chronic disease burden is because of the social determinants of health, of which we know structural racism is a driving force. So it's all linked, and so it's all systemic. And so I will say, when the Surgeon General Jerome Adams implied that, you know, this is more, you know, individual issue versus a systemic issue, and that we just need to stop smoking and eat healthy, you know, it's obviously much more complicated than that. And I think that was actually a sort of intellectually lazy response, but also one that is not supported by the data that we have, that, having adequate housing, having access to gainful employment with sick leave and benefits, having access not just to healthcare, but quality healthcare, having access to healthy foods in your neighborhood, all of those factors influence a community's health. And so I would say what has happened is that structural racism has left our communities sick. Like our communities are sick. And so when a pandemic like this occurs, it's putting a crisis within a crisis. And so we really shouldn't be surprised that we're seeing these numbers. We should be appalled, but not surprised.
And I guess I'll interject here and probably ask my question, and that is, how do you think that health policy will be changed from this pandemic in terms of trying to get health equity without a pandemic being here to exacerbate the discrepancy?
Right. Yeah. I mean, I don't know. I mean, if this pandemic doesn't shift policymaking, I don't know what will. But I think this just emphasizes that we need to focus on the social determinants of health. Like, that's where equitable resources should be going to in our communities, so ensuring that we have a safe and adequate housing. And also, I think even working with community-based organizations who are already doing this very important work will also be key to improving the health of our communities.
Okay, and in following up with that, there's someone, Lael Freeman, who asked the question: how does one launch an outreach program? What resources are available? Like, how can other people be part of this process?
Right, that's such a great question. So I will say, like, definitely, you know, this obviously varies state by state and locality by locality, but here in New York City, you know, our Office of the Public Advocate and a lot of our local government officials are actually having very close conversations with community-based organizations around messaging and outreach to Black communities. And so I would probably, you know, contact either like your local representative or your public, here we have a public advocate, because there are people on the ground already doing this very, very important work, working with faith-based organizations, working with neighborhood coalitions to ensure outreach to community members.
Yes, and Enid Montag, actually, her question sort of echo what you just said. She says that she read one of your article about leaving academic medicine and would like to hear your advice for academics who want to work and improve equity within an academic setting.
Oh, that's such a great question. Yeah, because that's definitely an uphill battle. But I will say, you know, one of the reasons why I left academics is because the particular institution that I was in, I felt like we really couldn't do the work that we needed to do in an authentic way. But I also want to acknowledge, I know not all institutions are like that. So I think it's really all about finding your allies within the institution that may not necessarily always look like you. And then also creating collaborations with community-based organizations as well. And because I think often what we do in academics is like we just are basically in our ivory tower, and really need to really be speaking with community members about what their needs are and what their concerns are.
Right. Okay, Dr. Moody-Freeman, did you want to ask any additional questions yourself that you didn't get a chance to ask?
Oh, so we don't have any more viewers' questions, because you know I have a million.
No.
Any more viewers' questions? Go ahead, Dr. Blackstock.
Oh no, I remember you had a question asking about. Did you have a question asking about like holistic remedies?
I did. Yes.
Yeah. No, so it's really interesting because many of my patients, especially the ones who have recovered and are coming back in, maybe they still have some prolonged symptoms, but overall they're feeling well. Some of them are Caribbean, and a lot of them tell me that they feel like they were able to battle the virus through different herbs that they that they, ingested while they were sick. And so and so they're like, what do you think, doc? And I'm like, well, even though there's never been a randomized controlled trial with garlic and coronavirus, I feel like if you feel like that helped you, then so be it. Because there must be something to it. And then I was just even looking up some of the Chinese herbal medicines, and they're actually doing some trials on herbal medicines. But what I will say is that obviously, you want to take, ingest substances that are going to boost your immune system. So obviously, we want to make sure, especially in the Black community, that we have adequate levels of vitamin D, which especially get low, in the wintertime. Vitamin C, zinc is great. And then a lot of my patients have been telling me they're taking elderberry as well. So I would say, yeah, definitely, I support whatever herbs that you think are helpful to you. The studies are not there pending, but also make sure you're practicing good hand hygiene and wearing your mask and doing all of that other protective stuff as well.
Yes, and I just wanted to, to follow up with what you just mentioned, somebody just asked the question that in some counties throughout the US, their health orders limiting the distance people can travel to 5 miles within their home address during this COVID-19 crisis. Isn't that inequitable? When you look at racially Black and brown communities, there's less access to green spaces and other exercising opportunities. And the reason they ask this question, this is relevant because if you develop your lung capacity and your respiratory health, you'll be able to better fight off COVID if you do happen to get it.
Well, that's interesting. I hadn't heard about certain localities and municipalities restricting movement or to that extent, but that definitely is concerning. And I think, these issues of equity that the person raises seem very valid.
Access to green space and being able to
absolutely. Because I think we can all acknowledge that this shelter in place has been and we haven't talked about sort of the mental or emotional consequences of this. I think many people are probably going to have, especially healthcare workers will have PTSD, but even people who are not working in healthcare, this is definitely very challenging and scary times, and getting outside even briefly, right, in green space is incredibly important to our well-being.
Right. Dr. Moody-Freeman?
I do. I have another question in terms of alternate treatments, right? So we talked about the Chinese herbs, we talk about Caribbean herbs. What about things like acupressure and acupuncture?
Oh.
Right.
Yeah, there actually were some smaller studies out of China with acupuncture, and I think some of the results were a bit equivocal. But definitely some of the patients had sought out acupuncture, and some just by report found it help their symptoms.
Yeah. Okay, good.
Thank you for asking about that.
Yes. Any final questions from viewers?
Yes, there's somebody here who left a question about, is there a way to track, let's see, wait a second. Do you find that the test to see, do you find that the test to see if you're infected come from China? Why can't we develop our own test?
Oh, you mean the PCR test?
I'm assuming they didn't really clarify.
So what I will say is that what's interesting, and so I think many of us, like we knew about supply chain, but I don't think we really understood it until now. So for example, some of the holdup in ensuring that we had adequate testing is that a lot of the pieces of the testing equipment, whether it's swabs or the reagent, like the chemical, the fluid used, are from all over the world. And so some parts are from Italy. So in Milan, there was one of the reagents for the PCR was made in Milan, and Italy had just been hit with the coronavirus. And so that impacted their ability to make these swabs. And I know that China creates some parts of testing, but this just speaks to globalization and how, you affect one aspect, and then it's like almost like a domino effect across the world, as we've seen even with the virus itself.
Yes, and that connects to, I feel like all the questions are all sort of connecting here, because there's a Melissa Chen, who's a medical doctor, what would you want to communicate to medical students or trainees about health disparities in the time of COVID? How do you communicate those inequities among your medical peers?
No, this is such a great question, and I think that medical education has done a disservice to students and trainees for a very long time. The fact that we haven't discussed healthcare inequities and health disparities in detail and talk about the structural reasons why we have these inequities and talked explicitly about structural racism has really done a disservice, because I think that clinicians, especially physicians, think that, oh, I treat my patients really well, and so I provide good care, so I don't understand what these issues are, when they really need to understand it from a broader view. So we talk about this, there's a term called structural competency, and there's this idea about understanding how practices and policies, how systems of oppression, how they actually influence patients' health more downstream. And so I think that understanding is really important and should be really a competency of clinicians, not just physicians, but anyone caring for patients, and especially caring for those of us from Black communities.
And there's I think that's good, because we also have a medical student here who essentially states that I'm a third-year medical student with a passion for health equity. I'm also a Black woman. And all that you've shared regarding social determinants and how communities uniquely impacted speaks to the core of what I and few other Black students at my institution value greatly, and what we have consistently tried to get my school to incorporate in our current curriculum since we've been here. And as a former academic physician, how do you, you've answered that to some degree. How do you get your institution to value this information, actually incorporate in the curriculum itself?
I know. The struggle is real. And I don't want to say the solution is leaving, because we have a place, we need to be there in these institutions. We have a right to be there as well. And so, I used to be someone who was like an incrementalist, that we just change a little bit at a time. But I would just say, keep fighting. Find your allies among the faculty, find your allies within the administration. Keep raising the alarm that this is important, just as important to know about as the Krebs cycle, as the Krebs cycle is. I am trying to be positive and hoping that institutions change. I think it will change as we see the leadership within institutions change, but that's also too long. That's too long to wait. So yeah, just continue the hard work. I always see it, the students are the ones that put the fire under our feet and the ones that really push for real change. And so I would just continue to do it. You're doing great work. I know it's frustrating, but you'll hopefully we'll see the fruits of your labor.
So we have 5 minutes left, and I do need to conclude, but I'm going to, as host, try to sneak in 2 more questions.
Dr. Moody-Freeman, are you still there?
Yes, I'm here. Can you hear me?
I think she's having some connectivity issue here.
No, I hear her.
Oh, okay. Yes. So my question has to do with whether or not, do you have any knowledge if doctors, Black doctors, Black healthcare providers in the United States are talking with other communities, say in Africa or in the Caribbean?
Oh,
would it help for them to converse?
Yeah, that's such a great question, and not that I know of. I don't know of any.
Mm-hmm.
It's interesting. I was talking to a reporter today from Newsweek UK, and about 40% of their healthcare workers are racial and ethnic minorities, and they actually were thinking about issuing a policy that would move them from the front line to doing other work in healthcare, because they didn't want to expose people who are already vulnerable to coronavirus. But it's just sort of interesting how in different nations, in different countries, people are handling this, and how we're treating communities and healthcare workers very differently.
Yes, thank you for that. So I'd like to invite you perhaps to tell everybody how you can be reached and how they can get in touch with Advanced Equity.
Sure. So you can reach me either on Twitter at Uche_Blackstock, or my website, www.advancinghealthequity.com. And there's a tab for contact. You can just put your information in there. So, and I also want to thank you so much for this opportunity. It's been a lot of fun.
You're welcome. Thank you for being here with us. I'd like to invite all of our viewers to tune in next week 2:30 Central Time, 3:30 Eastern. We have Dr. Joy St. John, who is the Executive Director of CARPHA, which is the Caribbean Public Health Agency. So Dr. Joy will join us from Barbados. The event is again scheduled for May 7th, 2:30 Central Time, 3:30 Eastern Time. Thanks so much for everyone. Thank you all for being here. And Dr. Blackstock, I really appreciate you taking time.
Thank you so much.
All right.
Thank you all.
All right, take care, bye.